So now we're going to talk about billing for the procedures that we do and the documentation requirements related to it. But we need to understand something called global surgery policy, because it has to do with when I can bill an evaluation and management in addition to the procedure. Global surgery rules don't permit separate reporting of an E&M when the E&M is part of the normal preparation of the patient for surgery or the normal post-operative recovery. CPT and Medicare have different rules. So in order to determine what is normal preoperative, intraoperative, and postoperative work for about 1,800 of the procedures that are in the CPT manual, mostly the orthopedic ones, the American Academy of Orthopedic Surgery put this text together. It's actually a 2-volume set, and identified content for each one of the CPTs of the preoperative, intraoperative, and postoperative. Now, that addresses all the fracture care that we do. It addresses the foreign body removals that we do. It doesn't address the laceration repairs that we do. But we can take principles from this, and by the way, Medicare uses this guide, the AAOS guide, in their determination of what's the preoperative work that's the normal work in order to determine whether an E&M should be billed. So Medicare uses this as their guide, and so I want you to understand the requirements that are laid out for pre, intra, and postoperative, so that you can know when you document a procedure in addition to an evaluation and management, when have you documented enough E&M to allow you to be reimbursed for both the evaluation and management and the procedure. Okay? So here's what is always included in the preoperative portion: local infiltration of meds and anesthetic and the surgical approach, exploration, isolation, and protection of structure. Surgical approach is, let's look at the body parts and body areas to determine how are we going to go at the process, go at the procedure. So if I've got a laceration, we'll say the laceration's on the back of my hand here, the preoperative portion, once I've made the decision that this needs to be sewn up, right? The preoperative portion of my work is to determine how am I going to do that, all right? How deep is it? Is there tendon involvement? Because that's going to, decide whether I have to do tendon repair. So how deep is it? Is it a dirty wound? Am I going to have to do additional management of the wound area? Am I going to have to cut away necrotic tissue or remove any foreign materials? That's all preoperative investigation of the area, right? So that I determine, am I going to use a straight line linear repair? Am I going to do a mattress repair? Am I going to need to do a multi-level repair? That's all preoperative decisions that you make, all right? Then, that's the surgical approach. How am I going to go about this? Then there's the intraoperative, insertion of synthetic bone. Of course, we don't do that. Wound culture, wound irrigation. We'll do irrigations. Position of imaging equipment, not the interpretation, but the imaging equipment, positioning it. Insertion and removal of surgical drains, closure of the wound, and the dressing, splinting, and casting. So that's all part of the intraoperative service. And then postoperative is suture removal. So those are the general rules taken from the AAOS guide that apply to all surgical procedures. Now we'll apply those to our most common surgical procedure, laceration repairs. So if in my preoperative, I've described that. The intraoperative is the actual suturing and suture management of the tissue. And then the postoperative is the suture removal, normal postoperative follow-up care. Those are all included in the procedure. So surgical policy says that anything that's included in the procedure can't be billed separately. But let's think about the patient who presents in the emergency department with that laceration repair. The patient did not come to us from another physician who looked at the patient and said, I've evaluated all the underlying medical problems. I've considered the issue of diabetic, whether they're diabetic. I've considered, there may be other complexities to this, like they're on blood thinners, and so now I've made all those decisions, and I'm recommending that this patient simply have their laceration repaired. If that was true, if that's how the patient presented to you, then you would not bill a separate evaluation and management, because all that work has already been done by another physician. That's not the way patients present to you, obviously. Those are all considerations you have to make. So you take an appropriate history. You do a physical exam, not just of the area of complaint, but you look above and below to check for signs of trauma elsewhere, right? You look to see where else is there some, possible fracture or trauma event elsewhere that's going to cause problems. So I'm looking outside the area of complaint. My normal workup is far beyond what I've seen required here as intraoperative. So that's all to say that I need you to comment on those things outside the surgical repair in order to get justifiable reimbursement for the evaluation and management. So what's not in the procedure? Supplies and meds, the wound closure, if it's a fracture, wound closure, and diagnostic interpretations. CPT's global service policy is that services provided by the physician to any patient are variable in nature. They differ on a procedure-by-procedure basis, and so the following things are commonly included. Local infiltration metacarpal digital block, so that's bundled, the digital block. Subsequent to the decision for surgery, one related E&M encounter on the date immediately prior to or on the date of would be included. But that's only if that was after the decision for the procedure. So if I decided to do the repair today and said, come back tomorrow and I'll repair that, the visit tomorrow could not include an evaluation and management because I made the decision today. But of course, that's not how we work. We decide we're going to repair today and we repair it. Okay? Immediate post-operative care, writing orders, evaluating post-anesthesia recovery, and the typical post-operative care. Those are all bundled into the evaluation and management. Medicare, so there's the, so Medicare shows the number of days that a patient is going to get their follow-up care included in their surgical procedure. That is showed in the final rule every year for every procedure. Now, 2 years ago, Medicare changed this. Here are your CPT codes, and out here are your global surgery days, and we'll see that for 12001, that's our minor repair for less than 2.5 centimeters. We'll see that it shows 10 days of post-operative care. Well, that was changed 2 years ago to be 0 days post-operative care. So no post-op management is bundled anymore into the surgical procedure. Medicare says that their payment for the procedure includes the preoperative visit, intraoperative services that are usual and necessary, complications post-surgery not requiring reoperation, post-op pain management, and supplies and related services. Now this is a coder-specific thing, but coders, you need to know that the Medicare rules for billing for post-operative procedures are different than CPT. For CPT, normal post-operative care is bundled, but if the patient comes back with a gunky wound after an intermediate repair, that's not bundled. That's a complication to the procedure. You would report that separately. for non-Medicare. Medicare says even complications post-surgery related to the procedure are bundled. Okay, so for Medicare I can't bill it, for CPT I can. Okay?
Now, what does that mean for us? Like if we see somebody for a post-op wound infection that's a Medicare patient, we're not getting paid for it?
Correct. You are not. Right, you are not. Assuming that you did the initial procedure.
It has to be the ER itself that done the procedure and they come back to the thing.
Thank you for clarifying that, because you all the time see wound dehiscence and, you know, stuff that, you know, surgical post-op, you know, and it's, you know, and it's all, you know, breaking open and stuff. Your bill will never be bundled into someone else's payment. That's a universal rule in all of Medicare, all of CPT. So the surgeon got paid for doing the post-operative care, right? If the patient had gone back there, he could not have billed for the post-operative work. Patient came to you, you didn't get the initial payment, so Medicare and the payers reasonably say, oh, well, I can't not pay you for this. Those are the most complicated, I mean, the most common wound complications, right? Stuff that somebody else did that you're now fixing. So those you document fully, and all evaluation and management related to it gets it. But if it's your laceration repair that went bad, those are the ones that you don't get paid for.
What about you're seeing it and then you end up consulting the surgeon that actually did it and they come and take care of it? Is that something different?
Well, yeah, because you're not going to actually, then you will not have done the wound dehiscence. Yeah, so you don't have a procedure, but you will bill the evaluation management where he can't. Okay? And he can't bill a reoperation. He's going to do that for free. Well, not likely he's going to want to come in for those, because, you know, they're bundled. Okay. He can't even bill for the reoperation. Yeah, he can't even bill for resuturing. He'd have to take, if it required that the patient go back to the OR, he could bill for that. Okay, but he can't bill for any management that he does in the ED. It literally says, you know, return to the operating unit. Then he can bill for it. This is what we looked at this morning, where we talked about billing for where before, post-op days, you know, they were bundled in, now they're not, so if I want to get paid for the full value of the laceration repair, I'd have to bill the post-op days.
Going back to this point,
yeah,
though,
yeah.
Is that for Medicare and private payers, or is it bundled with private payers?
Private payers have begun to follow this because many private payers tag their payments to percentage of Medicare. So they'll pay, for instance, Aetna will pay like 120% of Medicare, right? So the Medicare payment went from 102 to 55. The payment went down. Why? Because they're no longer paying you, just like Medicare, they're no longer paying you for the initial value, so you should be billing them.
So it at least means we should look at encouraging people to come back for suture removal. If they're going somewhere, if someone's getting
Correct.
paid for it.
Correct.
You can get paid for it now.
Yes, you can.
Might as well
that is true.
encourage that, and they should be registered.
Right. They should be registered.
Seen by somebody.
And that's correct. Registered and billed. You know, it's again, it's a policy issue. You know, there are policy implications. Do we want to encourage the patient to go back? Yes, we do. If they go somewhere else, will they get a bill? Yes, they will. So they're going somewhere else, they're coming here.
Because before it didn't matter, we weren't going to get paid for it.
Correct. You weren't going to get paid for it.
They
could go wherever they want. Go home, see primary care. They'll take care of you. They will bill for it. But now, if they come back here, we'll bill just like they bill. Okay? Or they go to the urgent care, wherever they get their post-op care. Same thing. So it's reasonable to suggest that they come back.
It will have to be done by the physicians, or can it be done by ancillary staff and billed like an exam?
Physician has to evaluate. Doesn't have to actually do the removal,
okay,
but actually has to see the patient and chart a note. Okay, so that's all to say. There are modifiers in play here. If the patient has a procedure and an E&M on the same day, we want to say, okay, we're smart enough to know the rule that I just described to you, that there has to be content outside the area of complaint in order to bill for a separate evaluation and management, okay? We know that, so we're going to put a 25 modifier on the evaluation and management. This is a coding issue, okay, 25 modifier on the evaluation and management to say, we know that the E&M is separate from the procedure. Payer reimburses us for both, all right? 57 modifier says on major surgical procedures, same thing, reimbursed for both the major surgical, that's any procedure with 90 days of post-operative care. Major surgical gets a 57 modifier. This is Medicare's own rule. Visits by the same physician on the same day as a minor surgery are included unless a significant separately identifiable service is also performed. So, billing for a visit would not be appropriate if the physician only identified the need for sutures, confirmed allergy and immunization status. If that's all you did, was say, oh, you got a bump in the head, I see the laceration, yep, okay, I'm going to sew that up, and I'm going to check immunization and allergy, and that's all I do, no separate payment for that. But if you do the evaluation that you should do, that's a normal, EMTALA screening. Let me check to make sure there's no injury elsewhere. Let me just check your vitals. Okay, everything looks good, now let me fix this. Payment for both. Same effectively is true of the major surgical procedure. The decisions, if all you did was simply look at the patient and decide to do the minor procedure, you don't get paid for both. So here's an example. We're just going to look at the charting of a couple of patients here to see how this pre, intra, and post-operative thing works. And we're going to paint the chart, different colors based on the pre, intra, and operative work. So here's a patient seen under the supervision of Dr. So-and-so, 78-year-old, sustains a laceration of the forehead above the nose, about an hour ago, no other complaints. Okay? That is all pre-operative, determining how am I going to approach, what is my surgical approach? Well, I got to know where's the surgical field, so I got to, figure that out. Oh yeah, it's in the forehead. Okay, and then a little bit of history tells me the mechanism, and then I've got allergy and immunization. But here's some outside the area of complaint. Here's a little bit of content that hangs out there beyond the surgical approach. She has no other complaints, and I get some past medical, right, and some medication history. Okay, so there's my preoperative tetanus status. Now, intraoperative work is all of this stuff. Describes the wound itself, 3 centimeters non-gaping, full thickness, skin margins jagged, and then the repair note itself. So this is our surgical procedure. We do the cleansing, the anesthetizing, the epi, 2060 interrupted proline, and then the discharge instruction, that's all intraoperative. And here's our little post-operative work, right? So everything that's painted is bundled into the procedure. The non-painted is my physical exam and history outside the area of complaint. So what have I got? A little orientation note, little tiny piece of exam, little bit of history here. Now, I sent this chart and a couple of others to both Medicare and CPT several years ago and asked them to determine whether they felt there was enough in this chart to bill both an evaluation and management and a laceration repair. This was their response. CPT wrote back, said, it's likely that there's a problem-focused exam that would be in addition to code for the laceration repair. Problem-focused, that's a level 1. Yeah, well, okay. This is really underdocumented. It's a 78-year-old. Fell, forehead. We didn't do a neuro. We didn't check anything else. No other complaints. No other system review request, any documentation of anything other than orientation note? I mean, it's a terrible chart. I mean, it's just a terrible chart.
But they used a lot of sutures.
Yeah.
Yeah, really. 26-0. Yeah, let's just pump this thing up.
Solid line.
It's a So here's so CPT, so I'll give you a level 1. Now, Medicare went farther than that. Medicare said, oh, look, there's an issue of reasonable and necessary here. In E&M may be billed depending on the extent of the history and exam. A person who sustains a superficial lack and that has no additional, walking into a jagged edge may only require the repair of the lack, as no additional head injury needs to be considered. But a reviewer in this case would feel comfortable coding this at a problem-focused level. A little more attention to the possibility of orthostasis or a neurologic exam in a patient with a head injury and laceration would have made this a solid, expanded, problem-focused exam. So Medicare went farther and said, if you'd have documented a neuro, this would have been a 3. As well it would have. Okay, so, but as documented, it could only be coded as a 1. So here's another patient. Now this is actually seen by a mid-level, and this is the same mid-level that we saw the last chart on, and this mid-level is struggling to to deal with emergency care. So this patient, seen under the supervision of Dr. So-and-so, this chart's got a problem because it's got a roving fracture. The fracture moves 3 times. Starts out on the left index finger, then goes into the proximal phalanx of the left index. Now we're down here to the 5th, and final diagnosis is an open fracture of the left first metacarpal. So where is it? I got 3 fingers here. I don't know which fracture this is. That's the first problem, right? So that's a problem in itself. Payers picked that up, by the way, when they read the chart. They said, I can't even tell you what CPT code to use for the procedure because I don't even know where the fracture is. But this is all preoperative stuff, okay? There's nothing there. 65-year-old injured his left index finger. How? What happened? Banging in the door? Fall on it? What happened? We don't know. There's the intraoperative. It describes the procedure itself, the type of fracture and how we managed it, and the disposition plan and the diagnosis. So this is the only content outside the area of management for the procedure. Not enough to bill a separate E&M. And that's what CPT said. They said no additional E&M would be allowed. Isolation, and so Medicare says, look, I'd caution you that isolation, neurovascular structure, wound debridement, reduction of the fracture, and closure are all part of the global service. I don't think it's prudent to bill an additional E&M as there's no significant medical service outside of the global procedure, the global service here. So here's another, this is another significant, this is a level 4 that goes undocumented. It's a fracture of the right humerus. 78-year-old right arm and shoulder pain. This is, again, this provider and triage stuff. I don't know how they ended up doing this, but 78-year-old right arm and shoulder pain, fell on the ice. Patient's pain is localized, the proximal aspect of the right arm and shoulder, and sharp in sensation, denies loss of consciousness, radiation of pain, numbness, and tingling. All right, nice system review. I got some good past medical there. I know how the mechanism occurred. There's my past medical. But my entire physical exam is constrained only to the area of complaint, the right shoulder. shows the edema, deformity, causing decreased range of motion due to the fracture, the swelling, motor strength diminished due to the injury, neurovascular intact. That's all related to the area of the fracture management. So I don't really have any significant exam. And like I said, you know, a 78-year-old who falls on the ice really needs to get a physical exam beyond just the area of the shoulder. Okay, so this is effectively a level 4, should have been, because of the right humeral head fracture. There's some significant risk associated with that, but we just haven't documented physical exam to support it. So ends up being no additional evaluation and management if we're going to bill the fracture care. Okay, questions about the E&M plus procedures? Okay, moving along. Wound repairs. Let's talk about how we document our laceration repair. We report lengths of what? What do we measure when we report lacerations? Length of the repair, not the length of the wound. Does it make a difference? You bet. Most often, I can't tell you the length of the wound. Where are the wound edges? Until I've cleaned it up and repaired it, I don't know yet where the wound edges are. Because I'm actually going to create some wound edge on some, you know, where I'm going to cut away some necrotic tissue, you know, on the outside. You know, I got to clean it up first before I can even tell where the wound edges are. So when nursing, even if nursing measures, they can't measure accurately because we don't yet know where the wound edges are until the wound is repaired, right? So we're going to measure all lengths of repair. So in a stellate lac, I got, you know, a flap coming in over here and one over here and kind of another one up like that. That might be 2.5 centimeters diameter. But if I measure all angles of repair, I may end up with a 4 or 5 centimeter repair. And I will encourage you to measure. It's been shown over and over again when it's studied that lengths of repair are 20 to 25% beyond what we estimated when we, you know, did the little fingernail or whatever, you know, little guess of what's, you know, 1 centimeter or 2 centimeters, whatever rule of thumb you use. I would just encourage you to use suture packs that have little, you know, measuring things in them, or because they don't have to be sterile. You know, this is after repair. This is wound's all cleaned up and ready to go. Then you measure the angles that way. So you have to measure the surgical field. Anyway, measure. You will find that lengths are greater than, and then measure all angles of any similarly classified repairs within the same level and body area grouping. So if I've got coders will know this, if I've got a single level repair on a 1 layer here, and I've got a 2 layer here, I would not add the lengths in reporting them. I would report them separately. But I want the physicians to document the lengths of repair on all of them, even if they were in the same. Don't just tell me that you've got, 10 total centimeters. I'd like to know where they are relative to how complex each of those procedures are. How deep are they? What is their complexity? Okay, are they simple, intermediate, or complex? And then measure each one separately. Note that laceration repairs that begin up in beyond the hairline and continue down to the face, those are 2 separate surgical codes. Why? Because they are 2 separate body areas. So the scalp is up here, or in mine, it's way up here. I don't know where you make the decision about, scalp versus face. Okay, but forehead is not scalp. So at some point, we are crossing over from the scalp to the forehead. Okay, so you will measure wherever lengths continue into different body areas. specific to the body area. So it may be a 10 centimeter repair, of which 6 centimeters are in the scalp and 4 are in the forehead. You document it that way. Those are 2 separate codes. And they pay dramatically more than just reporting a single 10 centimeter scalp repair or a 10 centimeter forehead repair. Okay? Okay, so how do we document our repairs? By layer. So we want to indicate the levels of repair of our layer, particulate, and contamination. So a simple repair is a single layer with no particulate, no significant decontamination required. It's a saline prep, or I don't know if you still scrub them. Do we use betadine anymore?
We don't tend to, but
yeah. Yeah, no, right, okay. All right. I know that was on the out. But anyway, so just, your normal cleansing prep is not, indication of decontamination. Yeah, we're decontaminating, but there's not significant additional contamination potential. Intermediate repair is 2 layers or a single layer with particulate or with decontamination. And a complex is 2 layers with particulate or contamination, or the physician's documentation of what makes the repair complex. Repairs on like, tissue that's hard to approximate, like on the face or on the ears, those can be really tricky. If it's a deep wound, getting the wound edges to close cosmetically or even close effectively sometimes takes good tissue management, right? You got to do the undermining thing or wound edge revision. Those are added complexities that may well take something from a simple repair to a complex repair if there are significant additional complexities associated with it. Okay, so describe how you managed the repair. Was undermining involved? Was there extension of the dissection? Meaning I had to go down in deeper because I was probing for tendon involvement in here somewhere, and so I had to get down in, or there was an opacity on the film and I wanted to be sure there wasn't a retained foreign body, so I'm down digging in there deeper, and now so now I've got to repair at a deeper level, and so what are your complexities? Document the complexities of the repair. The coders will then be able to look at it and say, okay, that's still an intermediate, or now that's moved over into complex repair. So some of the complexities are wound edge revision, undermining. When you're trying to get the skin to come over, you got to separate it from the lower portion to get it to pull over the deep V. Extensive debridement or removal of necrotic tissue or emaciated wound edges. Those are examples. Extension of the dissection. So, good procedure note on these more difficult repairs. A dog bite is an example. Where you got to get in, you got to excise open, you got to open it up, right? And get in there and see how far was the tooth damage. And now I'm digging deep in here to try to pull all this gunky material out, or it hasn't yet gone gunky, but it will. So I got to unroof the thing, and then I got to find a way to get it to close across, or however we're doing it these days to try to reduce the infection. Or human bites. I mean, human bites are the most biggest issues with contamination and infection and so forth. So, how are you managing the complexity on those? Coders, we will code and report the procedures in order of complexity, highest first. This helps the payers recognize if they're going to use multiple procedure payment reduction. We always like to do the sequencing for them, show them the one with the most charges or most RVUs first, and so forth. So multiple surgical repairs, multiple fracture and surgical repair, we'll put the highest value first on the claim line. We will code debridement separately when it represents areas in a separate location. So if I've got a laceration right here and it includes debridement around the area in order to, and as part of the procedure, I will turn that into an intermediate repair if it's single layer, okay, because debridement increases the level of complexity. But let's say I got a laceration here and I've got debridement up here. Not part of the, even though it's in the same general area, I need to know that. Okay, so physician, you're going to want to tell me that the laceration was 4 centimeters, just north of the elbow, but that the debridement was beyond the laceration, and in 20 centimeters elsewhere on the arm. Because now I can code both. Otherwise, I can't bill if the debridement is in the same area, I'm not going to know that I can bill it separately. I'm going to think that I have to bundle it into the procedure. And there's significant, these days, there's significant additional reimbursement for debridement. Basically, debridement RVUs went up like 50–60%. They redefined debridement. We'll talk about it in a little bit. But the RVU values went up dramatically. But it's related to how much body surface area you have to debride. So if I've got, the old road rash, the motorcycle accident, the guy hits the road going like that, I've got 20 centimeters over here and I got 20 centimeters over here. I need to know both of those locations and total body surface area for each, because I can report them separately. And now I get paid by the square centimeter almost. Okay? Okay, so tell me whenever debridement is outside the area of the repair. And then we always want to know mechanism, because it helps us determine complexity of repair. If it was a stellate lac, or if it was if it was a shear force injury, macerated tissue, down to the bone. So, we just need to know how it happened. Chainsaw accident, that implies all kind of infection possibilities, and so we need to know that stuff. I guess what I'm saying is, don't bury it, don't leave it up in the triage note. Okay, bring it down into the procedure note, or don't leave it in the nursing note somewhere where it's obvious to everybody else. But when we're coding that procedure note, let's get it in somewhere close to the procedure. Dermabond has its own coding issues, but it's another closure technique, just like Vicryl or nylon, and so can be reported. All right, let's talk about lip repairs. Some confusion about lips, because there are some codes out there for through and through lip lac, split lips, that we need to talk about. So, and they have to do with where the vermilion, where the split lip occurs. Now, the fact that the physician mentions vermilion, coders, that doesn't tell us enough yet. It tells us, 2 centimeter repair into the vermilion border, tells me that I had this is a punch injury out here, and it continues past the vermilion border into the vermilion area of the lip. Okay, physician's going to tell me that, because that's kind of a hard approximation to do there. That's a very careful repair that needs to be done for good cosmetic effect, but it doesn't change the code. So if it's a 2 centimeter easily approximated, that's a 12011 simple lip lac. It's a 2 centimeter with extensive cleansing required. Now it moves from simple to an intermediate, 12051. And then it's a 2 centimeter with 4 millimeters across the border, requiring tacking sutures for careful approximation. Now I'm talking about an additional complexity to the repair, because we really don't want, a cosmetic defect right there. And so we're going to use a careful, complex repair technique, tacking sutures in the vermilion area, and so we want to report it as a complex repair. Okay. Now, what do we do with split lips? Okay. Well, we have multiple codes to report for split lips, depending on how far the split is into the lip. Now, a split is a true through and through, inside and out repair. Okay? So if it's less than halfway between the frenulum and the lip edge, okay, less than half height is the less than the distance. So a repair down to there, 4065. If it is half height or thereabouts, about 40652. If it's the full length, so if it goes down to here, that's half height. There, that's half height. Here, all the way down to the frenulum, that's full height. 40654. Significant RVU differences. Now, those are the really obvious ones. The ones we commonly see are up here. Notice that the split area to the frenulum is not very far. So it's quite common to get a split lip right there, right? Now I've got 40654 from there to there, and I've got a facial lac from there to there. Okay, but I need the physician to tell me that. How far did you have to repair? Now these are, you know, these you'd like a plastic surgeon around to do. I don't know if you get them, but they're almost impossible to come by in most of my clients' ERs. So, you know, you're it. You're the plastic surgeon. And is that an expensive repair? You bet. That's an expensive repair. Questions about lip lacerations? Okay, let's talk about fracture care. Splinting for fracture care, if, you know, well, let's talk about fracture care first. Use the fracture care codes only if the emergency physician has done everything the orthopod would have done in the initial management had they been willing to come into the emergency department. Meaning, you know, if all that was necessary was, you know, it's a distal tuft fracture, so we're going to place it in a Velcro splint, or it's a toe fracture, so we're going to buddy tape the toe. You did exactly what the orthopod would have done had they been here. Your definitive management is the same as theirs. You're billing for the initial fracture care. Okay? It's a rib fracture. What's the orthopod going to do? Probably not even as much as you do. Okay? There isn't anything to do in terms of invade or poke or push or strap or splint anything. But you're going to tell the patient don't bang it again, and, you know, don't play soccer for 6 weeks, or, you know, whatever your specific instruction. Those are appropriate use of the fracture care codes. Now, splinting for treatment later by another physician is considered supportive care, so we're going to bill only the splint management if we're effectively splinting now in order to have the ortho do the definitive management. Okay, those fractures that are going to the OR, we're not claiming those. Okay, the stuff that needs to be seen by orthopedics tomorrow, you know, to get proper alignment, and, you know, we're not, you know, the foot's so swollen that, you know, nobody's going to boot that thing today. And so if we just want to report the splint management and the, you know, the orthopod do the fracture care 2-3 days from now, that makes sense. Totally makes sense. But there's a whole bunch of the minor fractures that we manage definitively that we should be reporting, and all the physicians have to do is mention the fracture and how it was managed. Did we splint it? Did we give pain med? Did we give, you know, supportive care? Okay. I won't get into this, but it's a coding controversy, but orthopods have already been taught that in many cases it's better for them not to bill the surgical procedure, but bill all the follow-up visits. So like those rib fractures, they'd never bill a rib fracture. They'd just say, come back and see me every 10 days for the next 3 months. Because Medicare will pay me about $110 for the rib, they'll pay me over $300 for 6 of your visits in the next 3 months. So just crank the visits and forego the procedure code. And that's basically what this instruction written by the AOS tells their management team. So you're not taking any money out of people's pockets when you bill for the the cracked the cracked clavicle or the rib of the nose or the toe. Smart orthos know how to move those patients and crank them through to generate their own significant additional reimbursement beyond the fracture care code itself. They give up those small fractures. They don't want them. Now in some cases they'll even say, don't even send them to me. We're so full of hips and knees, that's what I want. That's what I want to fill my waiting room with, hips and knees. I don't need your little finger fractures. Send those to primary care. I don't know what your orthopedic service is like here, but that's just to say, don't be afraid of coding these. They're getting paid very well for their fracture care, even when they don't bill it as fracture care. So coders know that. Document the anatomically precise bone, please. Tell us where it is, what you did to treat it. If reduction was done, we really want to know that. On a Colles fracture that we might be sending to orthopedics in a day or two, if it needs reduction, I need to know that you actually reduced the joint. Don't just say fracture with manipulation. Well, if it's a mid-shaft fracture, yeah, you're going to manipulate it to get it to realign, but you're not doing the definitive management there. That may well have to be, surgically managed. So I'm not going to bill that. But if you've got a dislocation like a Colles at the joint, okay, and I'm relocating in order to get the cock up or whatever you're using to manage that. Orthopedics might eventually be doing the definitive fracture care. I want to get credit for the relocation of the joint. Pays pretty well. So tell me that it was a joint dislocation, not just that you manipulated the Colles. Tell me there was a joint dislocation that we, relocated. Okay, radial ulnars, but the same thing with the ankles, the medial malleolus and the bimalleolar or trimalleolar. There's an ankle dislocation associated with it. Tell me that you recognized that, you realigned, took care of the joint problem. This is for coders. Coders, please recognize radiologists do not diagnose fractures. They tell you what they think they tell you what they see or what they think they see on the X-ray. They don't diagnose fractures. There is such a thing as clinical fractures. Clinical fractures are fractures determined without imaging support. Some fractures cannot be seen by imaging. So do radiologists make mistakes? Yes, they do. So do we. So we may miss fractures just like they will. But that's also to say there are a whole class of fractures called Salter fractures, usually associated with growth plates in kids, where nobody's going to see the image. Okay? But it's going to be treated like a fracture because it has point tenderness, it has all the characteristics of a fracture. We're going to manage it like a fracture. We're calling it a fracture. It may be reported as fracture care. Splinting and strapping, I think we talked about this a little bit. Splinting and strapping, we do not report these in addition to the ortho codes. There's no universal agreement on what constitutes the physician's service. That is, do you have to put it on yourself in order to report it? Most orthos don't. Should you do something? Yes. The physician's service is to make sure that the splinting was effective. That is, it's supportive and it doesn't compromise neuro. So check their neuro status. And if you want to get credit for the splint, check to be sure that it was placed properly. It's good risk management. And things like air casts, anybody can put those on. You probably don't have to check an air cast. But if it's kind of a fixed or a composite, one of those things where you make the cast the, yeah, orthoglass. You know, if it's an orthoglass that we're doing in the ER, you know, you're going to want to make sure that we didn't put it on too tightly and constricting and so forth. So check them. And a temporary, just to get the patient to the OR, that's not an appropriate use of the splint and strap. Procedural sedation, we do some amount of that. Issues with that now. I don't know if it's inadvertent or not, but 2 years ago CPT changed the definition of how to count time and in effect precluded our billing most of procedural sedation. Effectively, what they did was say actual time, so payment is for the first 30 minutes of procedural sedation. Okay, first 30 minutes of procedural sedation. And the new CPT rule 2 years ago was that any time element, the physician must have performed at least half of it in order to get credit for that service. Meaning that in order for us to get credit for 30 minutes of procedural sedation, we have to have been continuously present for, 15 of the 30 minutes. Well, I hope your procedural sedation isn't normally taking 15 minutes to do, right? Because normally we can crank those things out in 6, 8, 10 minutes, right? Let's get the kid under, get in, get out, move it on. Once in a while, kid doesn't respond, starts waking up, we got to knock them down again. You know, we got to hang around and make sure that it all works out. We got to watch them afterward. You know, once in a while it takes more than 15 minutes. Well, by strict CPT rules, you have to document your time of procedural sedation now. Now, the time of sedation includes not just from induction to reversal, but any time you spent with the patient before or after. But it has to be continuous time. No, it gets more complicated than that. But bottom line is it has to be continuous time. The greatest amount of continuous time you spent pre-induction, induction, reversal, post-reversal, continuous time. Document your time. What can I tell you? Now, that's if you perform in support of somebody else doing the procedure or you're doing the procedure yourself. 2 separate codes, but you have to document your time. EKGs and X-rays, I'm not going to go into the politics of that, except to say that the OIG, again, came out in support of payment for the contemporaneous interpretation of the EKG or the X-ray, not the post-service reinterpretation of an EKG or X-ray already read by another physician. You, meaning radiology and cardiology, shouldn't be billing for this stuff. Never should have. OIG looked at this way back in 1993, wrote the recommendation. Medicare said, we're not observing that. Just last year, May of last year, they published another report that said exactly the same thing. Medicare, we're recommending that you stop paying for reinterpretations of X-rays and EKGs. Medicare says, nah, never mind. We don't want to get in a fight with a radiologist, so we're going to leave it alone. There are still coding options for X-rays, but you have to be willing to take on radiology a little bit, get them to comply with the date of service reporting requirement, some other stuff. Won't go into it here, except to say that, again, OIG says the contemporaneous interpretation is the one that has the value to the Medicare payment system. Okay, EKGs. So let's talk about what do I need in order to bill a 12 lead or a 3 lead. Well, first I need to have, in my record there should be a separate paragraph for each EKG interpretation. There should be a separate section. It doesn't have to be a separate piece of paper, but it needs to be separated out in your, it's a diagnostic interpretive study. It needs its own note. So first EKG, and regular rate and rhythm, no ST segment elevation, normal access, normal EKG. Second EKG, and so you can document each one in its own separate note. Yeah.
We routinely get EKGs transmitted from pre-hospital. When we interpret those EKGs, those patients oftentimes go directly to the cath lab. Do we have the ability to bill for those EKGs because we're technically interpreting them?
Yes, you are. When you say they go directly to the cath lab, do they not even stop? They don't pass go. They don't. Really?
Giving heparin pre-hospital for those patients coming in from Walworth.
Oh, Walworth, that's why. Right, because they got an emergency evaluation out there.
But even
No,
some
no.
they're going straight.
They come,
Really?
From their home. Yeah.
I've not seen that before.
Straight to the cath.
Huh. Cardiologists are good with that.
as long as they're,
How about
as long as
that?
they have the cath lab ready, they don't have to stop. They just-
Yeah. Okay. All right. Haven't seen it before.
So you can see cardiology's billing for those. We're the ones that see them.
Well, yeah, the cardiology wouldn't be billing the EKG because they don't have it. It came to you. I mean, they don't have a strip. So, I mean, if you didn't see the patient, I'd have to think about that one. I haven't encountered that before. But the EKG comes to you, but the patient doesn't.
Correct.
Interesting. Well,
But cardiology that bills for the EKG a day later,
I know.
they get
Right.
EKG but not the patient either. So what's good for the goose should be good for the gander.
Yeah. I'm not even sure. Why do you get the EKG?
Hospital receives them from pre-hospital providers. They run the 12-lead EKG.
Right.
And some of our services are not paramedics. They're basic EMTs in Wisconsin. They transmit the
Really?
EKG to us and we interpret it.
You interpret it. You say,
We say it's a step.
ST elevation, MI, get them upstairs.
Yes.
They go.
Not every time, but good proportion of them.
How about that?
And at times if that is not working and they read it as a STEMI in the field, we go by that and we still go straight to the cath lab.
Right. Yeah, so they don't have, so you do have some paramedic read EKGs.
Yes.
And when you do you get those also?
Yes.
Well, what is the, I have to think about that one.
That's your challenge question.
Yeah, really, because it's got EMTALIC questions in mind and stabilization. Okay, cool, interesting. Well, time is heart muscle. I get that. Time is muscle. Okay. We don't want to report 12 leads as 3 leads. That's fraud. We can report our 3 leads. We talked about that this morning. Now, when you do a 12 lead, in order to be paid for it, you want to document at least 3 of these 6 things. Rhythm and rate, axis, interval, segments, comparisons to a prior, or clinical conclusion. Those are the 6 common components of an EKG. Any 3 of those, and that is considered equivalent to a professional in the field. So, examples that are not consistent with the professional interpretation of an EKG. So here's basically a clinical conclusion with a comparison. There's a clinical conclusion, but no other content. So these are too skinny. Those would not be separately reported. No need to talk about x-rays. Emergency ultrasound, that's right, we're starting to do them. Okay, a key issue is retaining an image. Got to be sure that you can file, it doesn't have to be an epic necessarily, but it has to be in a retrievable form. So you got to buy one of those ultrasound machines that you can store all the images, once a year, offload them into you can put them in a separate file somewhere, but they have to be retrievable. So copy the image, and then your comments, 2 or 3 clinically significant findings from each ultrasound. And you know, in a separate line in your chart, not to be fancy, but you know, here's my emergency abdominal ultrasound reveals, you know, and and then, you know, Morrison's pouch and all the stuff you want to say on that. Okay. Okay, there's an example of a fast exam. It's got the 2D echo, transthoracic cardiac, and then the abdominal real time, which is limited. So an example of a fast exam would be a fast ultrasound, shows good cardiac activity, no pericardial fluid. Abdomen notes Morrison's pouch, no free fluid. Bladder is full with no surrounding fluid, and splenorenal recess has no free. So that would be an example of an appropriate fast exam. Now, lots of people are doing them for lots of other stuff, placing lines, you know, all kinds of things. So,
on the line placement,
yeah.
do you still need to have a picture of the needle in the vessel for someplace line?
To show that it's in the vessel, I think, afterwards.
Yeah, it doesn't, yeah. Where exactly? I'm not even sure that you have to have a picture of it in the vessel. I'm not certain that's the definitive. I think it's a good idea because for risk management, that's what we want to prove. We got it in the right place. But a stored image, even if the image is just that the vessel is patent before we go in, that we can see that there's no occlusion there, and I now have my pathway, you know, is clear to where I'm going in, that would be a reasonable storage of the image. You decide. What's the best image to retain for risk management? I got it in the right place? Yeah, it's probably a good idea.
I'm just so happy I got it in the right place.
Yeah. Oh, yeah, well, yeah, you got to punch the button, man. That's got to celebrate that. Incision and removal codes, INRs, let's just remember. In order to bill for an incision and removal, there has to be an incision. So just, you know, tweezering something out or expressing something in IND is actually an incision and drainage. Expressing is not, you know, unroofing is, expressing isn't. So if you unroof in order to express, tell me that, because then I get the incision and the drainage, right? But if all we're doing is expressing, it doesn't qualify. Specifically, an incision has to be referenced. Doesn't matter what tool you use, scalpel or needle or whatever, but you got to go in. Epistaxis, this is a coding issue I'm not going to cover with you guys. That also is a separate coding question. What about incomplete procedures? We talked about the debridement already. There are separate codes for debridement. Here's what they pay. Significant RVUs beyond the old codes where I had only 0.7 or 0.86. Now I've got from 1.4 as much as 6.25 if I'm debriding down to the bone. So for the debridement description, I need to know total body surface area and total depth. How deep? Didn't have to give depth before. Now I need to know how far down. I've got, you know, surface layer. I've got through the surface down to the muscle fascia or muscle, or past the muscle down to the bone. Those are my three separate layers. I need to know how deep and how wide. Okay, and the total body surface area of each one of the debridements and where they occurred on the body, because they will be reported added together or reported separately depending on the body area. Central lines, old coding issue, codes have been replaced. CPR we talked about. When it's done en route, hey, I got to know that it continued in the emergency department because it pays really well and I want you to get credit for it. So just let us know that.
Can I ask you a question?
Yeah.
So I'm routinely out with pre-hospital providers. So if I'm with them in a cardiac arrest and I'm present and doing CPR with them,
yeah,
that time can be captured?
Absolutely. Absolutely.
And then how would you incorporate that into the chart? Like I would just come in and add a note to the ED receiving attending that I was present during the part of this?
Sure.
You just have to be the whole care.
Yeah.
That's right. Get off the rig, get into the ED. No, physician-assisted CPR is...
As long as a physician is there.
Correct. Correct.
An AFib, RV, or FI?
Now, it does matter that the patient comes here, not somewhere else.
Correct.
Okay, so if they're coming here and it's physician-assisted CPR, that's all good. And the patient is critically ill, so you're performing critical care. If CPR is going on the entire time, then obviously there's no critical care. But that can be separately reportable. Defib, elective cardioversion on atrial fib patients, there is a separate code for that. We need to know that you did do the lower joule rate. This is not emergency cardioversion. We're trying to shock them back. This is the, cardiac arrhythmia that we're doing the low joule rate and probably giving them some sedation to calm them and syncing and all that. So talk about the syncing, talk about the low joule rate. The purpose of the cardioversion is in order to, try to restart the electrical sequence. And so anyway, that is separately reportable, but it has to be clear that that's what was going on. Just tell me that if you only tell me we cardioverted this atrial fib patient, it's not going to be, the payers are not going to like that. Coders are probably not going to be comfortable unless you describe that it was elective cardioversion in the way that I described. These are codes we don't commonly report in the emergency department. Used to back in the day. I think that one is now gone. Gastric intubation. It's a nursing service. Stool guaiacs, urine caths. Not normally physician services anymore. Pulse ox is off the table. We don't report those. 99288. Separate issue, but two-way interaction with the field is required in order to bill 99288. If that's happening, if you're actually talking to the field, but it kind of sounds, well, I don't know. Are we doing base station medical command here?
Yes.
Occasionally.
And the patient does come here. Okay. That code is in play.
Medicare stopped paying that.
Yeah, Medicare doesn't pay it. No. Privates do. Privates do. Yeah, right. Not an insignificant amount. Yeah. After-hours services. Do we report after-hours services? Okay, that is an allowable code. Most insurers don't want to reimburse for it, but it is a recognized CPT code for the emergency facility. Used to be that there was some question about the code. Did it really belong in the ER? It was kind of one code for everybody. Now there are separate codes for after-hours service in the office, after-hours service in the nursing home, after-hours service in a 24-hour emergency facility. So there's no doubt that 99053 was intended for use after hours by the emergency physicians. So it's a legitimate code to report, and not a lot of payers will reimburse for it. Some will. It's a reasonable code. Calls to the inpatient floor, those are separately reportable. They need to be documented. If you're covering the floor, coders need to know about that. They need to know when it happens so that they can get out and pull those charts.
If we respond to codes,
Yeah.
and as long as we document on their chart,
Yeah.
does that get picked up by anybody?
I would think the inpatient coders would probably pick it up. I wouldn't see the chart if it's an inpatient chart.
Okay. But it's something to check. I mean, it's not big money, but it'll, however many times it happens.
We intubate people, I mean, it happens enough.
Right. Oh, those intubations pay very well. Or, hopefully you're not having to hang around to do 30 minutes of critical care, but CPR, if CPR happens while you're up there, your intubation, patient goes into VFib and you're there while they're doing, document all that. That's all separately reportable and separately payable. Reported as an inpatient service, even if they bring the patient down into the ED. That's a separate coding issue, but anyway. Okay. Program isn't over until you've asked your last question, so please feel free. You have my email on the handout. Please feel free to email me. Happy to do the email thing. I'm harder to reach by phone, but not impossible. But frankly, in a complex question, it's often easier to talk it through than it is to type it out. But please feel free to continue to shoot notes and questions. Happy to take them. Any other questions at this time?